Um, my presentation will really focus on local evidence in terms of the barriers to implementation. And just to also indicate that as a program, we've been driving TB infection control for a number of years now, and it hasn't quite taken off, which means there probably is something wrong that we're doing around TB infection control. I'll highlight some of the issues as we go along. So that will be my focus of the presentation. And just on some of the barriers that have been identified, and this is based on mostly qualitative studies that have been conducted, as I said. One of the studies which was looking mainly at the infection control practices noted that the most frequently reported barriers to implementing good infection control practices was lack of equipment. And these were highlighted as masks and disposable respirators, and the structure, facility infrastructure as well, in terms of the layout of most of our PHC facilities. The other study which was done looked at major barriers to infection control, as including poor infection control training and conflicting policy guidelines. And these were mainly looking at the existing policies, which were around ideal clinic and the national standards, cost standards, and the TB guidelines. There were also low levels of motivation of staff that were observed amongst the participants that were interviewed, which were healthcare workers, and some were actually community health workers. And then there were feelings of powerlessness amongst the staff in terms of influencing, especially the infection control people or managers, in terms of influencing staff. There were also negative attitudes around healthcare workers, poor district health support to facilities, and there were also other general health systems issues that were actually identified. And in addition, most of the behaviors that were necessary to achieve risk reduction for TB were regarded as easy to accomplish, but they were impeded by the issues that were raised earlier. Now, an interesting study, the interesting findings from the same study raised issues on policy conflicts, as I indicated. The responses from the people that were actually interviewed here indicated that the conflicts between the national cost standards, the ideal clinic, and so it made it difficult as a middleman, being an operational manager. You end up being confused because the ideal clinic says you must not have a separate TB room, and TB falls under chronic conditions within the ideal clinic, and yet the national cost standards were saying that you must have a TB cubicle. So that was a major confusion for facility managers in terms of how do they address this. Another one said they say if someone is on treatment, then he is no more infectious. So really we query that, but we don't know. And that is what was stressed under the ideal clinic. Another respondent was actually said that when you read the policy, you see that it doesn't affect people at primary healthcare level. It's mainly hospital-based, and that's a problem for them. In a separate report, which was mainly published in a health systems reform, South African health systems reform document, which was based on 2 observations in 2 clinics in the Western Cape, found that the health system barriers were identified as follows. Leadership and governance were top-down and fragmented. There was lack of funding, which was a major barrier. There were insufficient numbers of staff trained in infection prevention and control, as well as occupational health. The occupational health services were not comprehensively available across the facilities that were actually participating in this, and the ability to sustain protective technologies was questioned. Lastly, a cross-cutting barrier was a lack of priority on TB cases amongst health workers in terms of screening of healthcare workers for TB. Now, again, it also identified that some of the barriers that were identified were inadequate training on TB infection control, a non-responsive compensation policy, and the perceptions that the facilities were quite busy. And this was done in high-volume clinics in this setting. And as a result, this left no time for TB infection control implementation generally. The paper also highlighted some of the key issues, one being that there was over-reliance on one person, and that would be the person that has been identified as an infection control manager. In cases of hospitals, that would be the person that would be leading the committees within that hospital. So this created a challenge in that there was no shared responsibility amongst the rest of the staff within that setting. Poor ventilation also came up as a major issue, and lack of prioritization of infection control now at a personal level. So people focused more on services than actually thinking about infection control. There was also a negative patient attitudes towards infection control, mainly looking at facilities. One of the facilities was enforcing that patients wear masks whilst waiting in the waiting rooms, and some of the patients refused to actually wear those masks. Healthcare worker perceptions on low risk of acquiring TB and attitudes on the use of PPE. In this instance, it would be healthcare workers thinking that they are at lower risk of actually getting TB and therefore not considering wearing of masks in the clinical setting. And in terms of attitudes, it was talking to the fact that the masks were uncomfortable, and there was reluctance to actually keep them on for longer periods of time. It also highlighted the need for constant supervision and leadership at all levels, and again, adequate funding for TB infection control. And the fact that the screening of healthcare workers was a voluntary service. So if you did not want to go for screening, then you didn't have to, and those that did would then access the services accordingly. There were also multiple contributors. This is now a study that was done, a separate study that was done, not linked to the previous study. And this was mainly looking at the barriers to implementation broadly, which found that there were multiple contributors to poor implementation of infection control. And I must say this was more of a systematic review as well of studies that were available. So some of the findings apply to the ones that to our setting, but it was a multi-country study. And then the highest risk was perceived to be from contact with patients taking TB treatment rather than from people with undiagnosed TB. The Ideal Clinic initiative presented opportunities for infection control despite the conflicts in the policies, and epidemiology of transmission in the clinics needs to also be taken into consideration. Mainly here looking at the fact that in some cases you find that the overall epidemiology is very high and others low. And even when you look at testing, the yields vary from facility to facility, and other patients are asymptomatic, and therefore you need to make sure that you consider all those dynamics. Poor ventilation also came up as one of the challenges, and variations in patient flow across the clinics is a major issue. And then healthcare worker perceptions and practices were also an issue, and these differed from facility to facility. I think, I made a mistake here. This is the study which I was saying it was a systematic review of all available studies that had been published. And when you look at some of the issues here, it was mainly around the lack of consideration of infection control, particularly as we try and integrate TB and HIV services, ineffective occupational health facilities and occupational health and safety policies as part of infection control, shortages of funding and resources, which keeps coming up in most of these studies, and the transition from policy to implementation. There seems to be a knowledge gap. Stigma was also highlighted as a main issue, and this was particularly from the healthcare worker side. And staff training ranged from those countries that had training for all staff to those that were selective in the staff that was training, and others no training at all for staff. Healthcare worker perceptions again came up, and this was mainly towards other people, family, and patients themselves within the facilities, and as well as towards themselves. There were shortages reported across most of these countries of the respirator masks, lack of authority to implement TB infection control programs, poor adherence to the infection control measures by staff, as well as difficulty in educating and sensitizing patients themselves. So you can see that there is some overlap in terms of studies done and what we've picked up locally, studies done in other countries and what we're picking up locally. Some of the lessons, though, which was that came up from additional studies, was that most anticipated improvements were dependent on healthcare worker adherence to the policies. There was a large variation in compliance to each measure. These two studies were focusing on quality improvement for infection control, which was quite interesting. And looking at each infection control measure or hierarchy in terms of trying to improve whatever the gaps that were identified in those facilities. And then again, the other factor within this, one of these studies was related to personal risk, which appears abstract and therefore difficult for some of the staff. And here it was speaking to, when I say staff, it was addressing both nurses, doctors, as well as community health workers. This one was the fact that, the risk is abstract, and infection control was also looked at as being burdensome. There was also a further barrier to compliance, which was related to stigma. Lastly, again, when it comes to the interventions, the simple interventions such as training workers on infection control, good quality TB screening, can initiate behavioral change from healthcare workers. Now, in terms of the interventions that would be required to address some of these barriers, just trying to summarize here. Harmonization of policies and adaptation to health system reforms as well as policy shift is critical. We need to also integrate TB infection control into the broader policy on infection prevention and control, rather than running it as a parallel program within facilities. We also need investment into TB infection control. This is in terms of human and financial resources, strong leadership and accountability at all levels, capacity building for all staff, ongoing mentorship as well as support to facilities, education of patients and communities, and lastly, clear indicators for program monitoring program implementation. So in conclusion, considering all the efforts that have been implemented in terms of infection control and some of these findings, and as well as the impact of all those efforts that have been implemented, one wonders whether we should not really be considering re-engineering of infection control generally. Obviously, then TB would be part of that, as part of the health system strengthening instead of the current programmatic approach. Thank you.
Thank you.